Hello, I'm Dr. Mas Chapanda, consultant physician at the Royal Liverpool Hospital. Today I'm going to cover aspects of pharmacology for the MRCPCH Part 1. We're going to look at drug interactions. These are very important in the exams. In terms of pharmacology, most of the questions will do with drug interactions. So to set the scene, we'll talk about the first drug interactions. So, question 1. In which of the following, when used in combination, is there potentiation of the second drug's action? Ranitidine and warfarin, erythromycin and theophylline, sodium valproate and phenytoin, rifampicin and glucocorticoids, phenytoin and the pill. Remember to read the question carefully and what they are asking. I'll give you a few seconds to consider. So in fact, there are two answers there which are correct. Erythromycin will potentiate and may lead to theophylline toxicity. Sodium valproate, when given with phenytoin, may potentiate and lead to phenytoin toxicity. Whereas if you look at rifampicin and glucocorticoids, rifampicin would lead to or would induce the breakdown, not the potentiation, of glucocorticoids. So this emphasizes the importance of drug interactions, especially in the exams, and I'll go through these very slowly because most of the questions are built around drug interactions around the cytochrome P450 enzymes. This is a group of enzymes in the liver which metabolizes drugs, and if two drugs are put in together, there is a potential interaction at this level. Just to remind you, it's a group of about 100 at this level. Just to remind you, it's a group of about 100 isoenzymes. The majority, therefore the majority of drugs in our body are metabolized by CYP3A4. There are some minor ones like 2B6 as listed there. The second caption that you have there, the table, gives you the important substrates, i.e. which drugs go through that particular pathway. And again, I'll highlight the ones that are important for the exams. I think the common one, which is not a 3A4, which is a 2C9, is warfarin. Time and time and again, you will see this in the exam. Warfarin is metabolized through 2C9. 2E1 has paracetamol, theophylline, and caffeine, and it's important for theophylline toxicity to know which pathway is it a substrate of. 3A4 is the majority of drugs, so atorvastatin, carbamazepine, codeine, and many of the drugs which are induced and inhibited, and we'll come back to that list. 2B6 has some minor drug metabolisms in there, such as erythromycin and methadone and efavirenz. Again, the importance of this comes when 3A4 is not the major pathway, and this has to do with genetic polymorphisms. Suddenly, 2B6, which may have been playing a minor role, takes on a bigger role. What does this mean for the exams? It means that we can split all the drugs in the exams into two useful lists: enzymes inducers and enzyme inhibitors. Enzyme inducers, and I'll put it to you, the way to remember it, induce the breakdown of the second drug, i.e. they do not potentiate, they induce the breakdown of the second drug. And a useful mnemonic here is CRAP GPs. So any of these drugs induce the breakdown of the second drug. For example, any of these drugs plus the pill equals pregnancy, because these drugs would induce the breakdown of the pill and suddenly the pill wouldn't work and pregnancy would be the result. So enzyme inducers, carbamazepine, rifampicin, which is probably the most powerful, which is used for treatment of tuberculosis. Chronic alcoholics, not acute alcohol, not alcoholic binges. If you see that in an exams, it is not an inducer, it is an inhibitor in that setting. Here, we're talking about chronic alcohol abuse as an inducer. Phenytoin can do it to a lesser extent, which is why it is not the preferred. Griseofulvin, phenobarbital, which is for epilepsy. Griseofulvin is for treating of fungal infections, especially fungal nail infections, and sulfonylureas for diabetics. Others, which are less common in the exams, but to be aware of, sulfasalazine, primidone, tobacco smoke in itself can act as an enzyme inducer. This is important in the exams. If you stop smoking and you're on theophylline, potentially you could die. What that means, to understand the mechanism, is that the enzyme induction leads to clinicians slowly increasing the dose of theophylline because of the drug interaction. But if you stop smoking, you take away that induction, theophylline levels will continue to rise and you will have sudden death from theophylline toxicity. I hope that is clear. That's a very difficult question in that scenario. Other inducers, so the oral contraceptive is a mild inducer of 3A4, spironolactone. Again, you wouldn't think of it as an inducer, but it's a mild inducer. And some of the HIV drugs like nevirapine and efavirenz, and they do auto-induction, so they self-induce. So for example, with nevirapine, you would start at half dose for the first 2 weeks, and once you have full induction, you would go to double dose, taking into account auto-induction. Then the other aspects, again, in the exams is enzyme inhibitors. And again, the easiest way to remember this is that enzyme inhibitors inhibit the second drug. Another way is to say they potentiate the second drug. And here, our mnemonic is O devices. So any of the O devices, omeprazole, disulfiram, erythromycin, valproate, isoniazid, ciprosimetidine, acute ethanol, sulfonamides, allopurinol, fluconazole, any of these will inhibit the clearance of the second drug. An example is any O device plus warfarin will lead to bleeding. It will potentiate the actions of warfarin. It will lead to inhibition of warfarin metabolism, hence the raised INR, hence bleeding. I think this is a very important concept to grasp because it will answer most of your questions for pharmacology drug interactions, which are very common in the exams. Just to remind you, disulfiram is antabuse for alcohol, erythromycin and ciprofloxacin are antibiotics, and these will cause potentiation of other drugs, even if it's used in a short-acting form, a week or less of treatment. Valproate is for epilepsy, and to remind you from the crap GPs that not all anti-epileptics are inhibitors, so we have phenobarbital and carbamazepine, which are inducers. Isoniazid is used for the treatment of tuberculosis, and I won't mention the others, just to mention that fluconazole is probably one of our most potent enzyme inhibitors. Ritonavir is an inhibitor that's used in the treatment of HIV. Finally, let's look at adverse drug reactions. Again, these will come up in the exams in various forms. Here's a useful table to help you think about adverse drug reactions. And this is the A, B, C, D, E, and F. So A are dose-related or augmented. And here you could think of digoxin. This is a dose response. The more digoxin I give you, the more likely you're to have digoxin toxicity. And you can get a dose response curve from this. B are the bizarre ones, which are unpredictable, no dose relation, so it's an idiosyncratic reaction. So for example, with penicillin, I cannot predict using dose or through any other knowledge who will get penicillin allergy. This is a bizarre idiosyncratic reaction which is unpredictable. Fortunately, in the exams, they tend not to ask about many of these bizarre ones. They will ask about the common ones which we would expect you to know. And then there are those which are due to accumulation of drugs, so chronic use, and hence C. So this is related to cumulative drug exposure. And the classic example in the exams are non-steroidal use, which induce renal failure. The more you use non-steroidals like ibuprofen, like diclofenac, over time can lead to glomerulonephritis and tubular nephropathy. And then there are those which are D, delayed response, so time related to exposure, for example, in utero. So this is teratogenicity, especially from the steroids. If the mother has been using, the pregnant woman, the pregnant mother has been using steroids, then we have a delayed effect where we'll see some of the teratogenic effects manifesting in a newborn baby. Then there are end of use, and these are very important in the exams. So sudden, abrupt withdrawal of medication can lead to adverse drug effects. And the classic example for this are steroids. If you suddenly stop prednisolone during a prolonged course, you can induce an adrenal crisis. Same thing with benzodiazepines. So to prevent end-of-use withdrawal adverse effects, the recommendation is tailoring off. So for the steroids, for example, you would go from 30 milligrams for a week, then you would cut that down to 25 milligrams, down to 20. So a slow withdrawal of about 5 milligrams per week. Again, with SSRIs, think about this because this is topical in the exams. And then finally, which is unexpected failure of therapy. In the exams, this will manifest itself with questions of drug-drug interactions, which I've recently covered. So this is looking at interactions, for example, of the pill when used with an enzyme inhibitor, or when an enzyme inducer is used with a pill. Again, you will see that either it's a potentiation or loss of function. And it's very important to classify drugs in this manner, as it gives you a systematic approach when you're studying for the exams, rather than looking at all adverse drug reactions as the same, which they are not. I hope this has been helpful for the exams, and I hope that